I'm going to talk about a physiologically difficult airway in the context of severe metabolic acidosis. Thank you to the Airway team and also to Dr. D'Souza for helping. So here are our objectives. So we're going to go over a case. This case is actually a case study published in the Journal of Endocrinology in April 2024. Can everyone hear me? Good. Okay. So we have a 6-year-old female, past medical history, hypertension, asthma, insulin-dependent diabetes. She comes in escorted by family for drowsiness and vomiting. Normally ANO ×3, but this morning not acting like herself, had several episodes of vomiting, no associated recent illnesses or symptoms, no recent travel. She has not been very compliant with her insulin administration per family. Here are her vital signs. So you can see pretty tachypnic at 36 and finger stick is over 500. Physical exam, somnolence, but otherwise supple neck, no focal neurologic deficit, soft abdomen. So I think we can all guess what's going on here. We got our first set of labs. So you see anion gap of 39, glucose of 650, and look at that bicarb is 5. So it's pretty solid DKA here. First VBG, pH of less than 7, CO2 of 15. So I know you're all calculating in your head the Winters formula right now, and you're saying, what is her expected PCO2? So we're looking at the CMP bicarb for this, and we're calculating that the PCO2 should be between 14 to 18, and she's at 15. So right now she's compensating for her metabolic acidosis. She's breathing off enough CO2 to compensate. But we get our second BBG, and now we see our PCO2 is 30, and our bicarb is pretty much the same. So now I know you're all thinking, oh my God, now she has mixed metabolic and respiratory acidosis because she's not able to compensate for the acidosis going on. So let's talk about metabolic acidosis and how we change our respiratory mechanics. So we all remember our equilibrium equation. So when we're in metabolic acidosis, we have molecules like ketones or lactate that are breaking down and forming a lot of H+ ions in our bloodstream. And our body's system for dealing with that is our buffer system with bicarb. So bicarb and H+ combine through an enzymatic reaction to form water and CO2. So our H+ ions are eating up all our bicarb and producing a lot of CO2. How does our body clear CO2? By ventilation. So we all remember our minute ventilation equation. Minute ventilation is the volume of gas we breathe in and out over 1 minute. So if we're trying to breathe off a ton of CO2, we're trying to maximize our minute ventilation. And our minute ventilation is the product of our tidal volume, which is the volume we're breathing, and our respiratory rate. So what do? In A, we have our normal breathing mechanics. So we have a normal respiratory rate and a normal tidal volume to make a normal minute ventilation, which is about 6 liters per kg per minute. But if we're trying to maximize our minute ventilation, we see in figure B, we've increased our respiratory rate, which increases our minute ventilation, tachypnea. And then in C, we've increased our tidal volume to increase our minute ventilation, which is hyperpnea. And in D, we've increased both. So we're maximizing that minute ventilation, and that's our Kussmaul breathing pattern. So in acidosis, we can increase our minute ventilation up to 8 times. So we're really breathing really fast, really deep, which doesn't sound very sustainable, does it? So why do we care about this? Acidosis is bad. Acidosis will wreak havoc on your body, but specifically, some things that we really need to focus on is that it can decrease your cardiac output. So acidosis can alter the sensitivity of your cardiac muscle fibers to calcium, so it decreases your contractility and your cardiac output. It can also reduce the number of adrenal receptors in your body, so it reduces the heart's ability to respond to catecholamines. That's pretty important, right? Think about your hypotensive patients maxed out on pressors. You're pumping catecholamines in. If they're acidotic, they're not as responsive to those pressors you're pumping in. So it's important to be aware of your patient's acid-base status. It also causes arterial vasodilation by altering the the ability to contract of the smooth muscles and the tone of the smooth muscles in the arterial system. And it causes a lot of other bad stuff. So acidosis is bad. We need to know how to manage it. What causes acidosis? Metabolic acidosis. We pretty much know this, right? Toxins, ketoacidosis, lactic acidosis. So there's other things besides DKA that can cause your patient to have the change in their respiratory mechanics. Like, for example, in salicylate toxicity, you have mitochondrial impairment and buildup of lactate, and you can have these changes in your respiration. So what do we do when we have a really sick acidotic patient? You want to resuscitate aggressively. So in our case, our patient has DKA. We're going to do fluid resuscitation, insulin drip, electrolyte repletion, whatever we need to do, because you want to avoid intubation at all costs. Because intubating these patients is super scary. You take away their respiratory drive, you take away their compensatory mechanism, they're going to become profoundly more acidotic and they're going to code because of all the things we've talked about. So sometimes you can't avoid it though, right? You have a patient who's totally obtunded, not maintaining their airway. But more importantly for these patients, you have someone who's no longer able to compensate. So you see, even though the Kussmaul breathing is our physiological response to this, once you see a patient Kussmaul breathing, you're thinking, okay, I got to plan ahead here. Like, I might have to intubate this patient, because you guys try breathing at 35 with a tidal volume of 8 cc's per kg for like hours. It's just not sustainable. They're going to tire out. So once you see that, it's their first sign that, aggressively resuscitate, but think in the back of your head, how am I going to approach this? How am I going to do this if I have to intubate this patient? So just a little sidebar here. Hot topic. Sodium bicarb. Do we give it? Should it be a part of our bundle of resuscitation for an acidotic patient? So let's think about it. What is bicarb? We talked about it. It's our body's buffer. So you think, you got a bunch of H+, you're acidotic running around your bloodstream, eating up all your bicarb. If I add more bicarb, shouldn't that help? So potentially we're thinking it will reverse some of the really negative effects of acidosis, like the decrease in cardiac output, the decreased systemic vascular tone. But think back to our equation there. We're adding more bicarb. It's reacting with H+. It's also creating more CO2. So if you have a patient who's barely compensating already, do you really want to add more CO2 into their system? I don't know. Basically, after a review of all this literature, there really isn't a straight answer to this that's evidence-based. There's no hard evidence to suggest that there's a decrease in mortality for patients that receive bicarb who are severely acidotic. There's also no evidence to suggest that there's harm. But the caveat is that most of these studies are looking at infusions of bicarb. So we're used to giving like amps of bicarb, right? What is an amp of bicarb? It's a very concentrated dose of bicarb in a hypertonic solution that you're slamming in at a really fast rate. So that actually, when you think about it, could cause some harm, right? You're rapidly increasing the CO2 levels in a patient, and you're rapidly increasing the tonicity in the blood. So basically, from what I've gleaned from all this research is that if you're going to give bicarb, if you want it to be a part of your resuscitation bundle, maybe don't give it as a push, give it as an infusion. And you could do that logistically by taking 3 amps of crash cart bicarb, putting it in a hypotonic solution, so like D5W or like sterile water, depending on why your patient's acidotic, and infusing it in a slow rate so that you're giving that liter over 3 hours. Most papers are looking at administering it as 50 MEQs per hour. So in that way, you're not suddenly changing the tonicity of blood, and you're not suddenly rapidly increasing the CO2 levels. Yes.
Remember that the Emerson house population, when you add bicarb H+, you get water and CO2. the bicarb, the acid can't really get into your brain because it's the blood-brain barrier, but the CO2 can. And they say that all that CO2 you produce so quickly can get cerebral acidosis. It's not really like proven to cause a problem. There's never seen a paper that shows it. But that's the theoretical risk of giving them the push to the brain.
And it also like makes your numbers look pretty, right? But what's going on, that those numbers aren't measuring what's going on intracellularly. So, right. You're making yourself feel better without actually necessarily making the patient better. So this is a little sidebar. Think about it. Back to this though. So you've resuscitated your patient. You're like, they're not getting better. I have to intubate. How are you going to approach this? So we know that when you paralyze this patient, they will become profoundly more acidotic and they will code. So that's why you have to be really careful when you're intubating these patients. So first you obviously are doing your resuscitation, and then just like any other intubation, you're pre-oxygenating. You can throw high flow on. One method that you could consider is doing like a non-invasive pre-oxygenation. So, and just a plug for the pre-oxy trial, everybody should read it. But one method is like you're going to have the vent in there anyway. You could take the vent, attach it to a BiPAP mask, put it on your patient, and put it in a mode that's like equivalent to a positive pressure mode. There's some vents have like a BiPAP mode, and some have like a SIMV mode, a synchronized intermittent mandatory ventilation mode. You could just turn the respiratory rate down to 0 so that, because your patient's not paralyzed yet, you're just pre-oxygenating them. They're breathing on their own. You're just basically helping with the helping them not to tire out as much by providing a little positive pressure. And then you pick your RSI meds. So you're in the room, right? When you're putting them on this mask, like you're not leaving them alone on the BiPAP mask, but you're picking your RSI meds just like you do for any other resuscitation. You're thinking about the hemodynamics. If I want to give ketamine, if they're unstable, if I'm okay with etomidate or whatever you want to give. And then you're paralytic. So even though you're thinking, oh, I shouldn't paralyze this patient for super long, maybe it sucks is good. You just have to be really careful because especially in like diabetic, like DKA patients, the potassium levels are extremely unpredictable. You don't want to cause harm or you're trying to do good. So just kind of thinking about that, like if you're 100% sure this patient is not like in DK and you're like, I know this potassium levels, like you could maybe think about sucks, but rock is always a solid option, even though it takes a little longer to come off. And then you push your meds, the patient becomes paralyzed. So they're stopping now to breathe. And this is the tenuous moment, right? If you decided to go with the non-invasive pre-oxygenation method, you can just turn the respiratory rate up to like 12 and let like the breaths be delivered that way while they're paralyzed. And this is maybe better than just putting your BVM on and giving uncontrolled breaths. Because like when you think about what we're doing when we're pushing air in with our BVM, we're pushing it in at a really high pressure, and usually the breaths aren't going exactly where we want them to go. Often they're insufflating the stomach. And, these patients are obtunded. Some of them might be like in DKA. They might already have gastroparesis. Like you're really increasing the risk of aspiration when you're just pushing like not uncontrolled breaths in with your BVM, unless you're doing it like really nice and slow and controlled, which probably isn't going to be the case in this context. This is just an alternative way of delivering nice, controlled, slower breaths at a known pressure to avoid those complications. And then you put your tube in, and this is not like I've never intubated before, I'm an intern intubation. Like this is the most experienced person intubating. They're going to get it on the first pass because you don't want to mess around with this. So then you've intubated and you're attaching them to the vent, but you are definitely not done, because vent settings are very important in this patient. So unlike the patient where you're like, yes, I intubated, high five, and walk out of the room and don't even look at the vent settings, like this patient will code if you do that. So you have to really think about what your goal is, right? The goal hasn't changed. We're maximizing our minute ventilation, just like the patient was doing. So right now they're paralyzed, so you're putting them on full support. Volume control is a good option. And your goal is hypocapnia. sorry, I forgot to mention the last slide that while you're intubating, you should have end tidal on these patients because the end tidal, like just like we're talking about how minute ventilation, hypocapnia is our goal with the respiratory mechanics of the patient, looking at the end tidal, seeing where it's at initially, and then your goal is never to let it go above because that means they're creeping up, they're becoming more acidotic. So always having your end tidal, but once you put them on the vents, your goal is still hypocapnia.
Don't forget when you give the paralytic, the end tidal is gonna go to zero no matter what it is, right? Because they're not breathing, there's no CO2 coming out of the body.
Mhm.
Don't rely on it, it's not gonna be any number to use it.
So you're putting them on full support and you're still trying to maximize your minute ventilation. So you're putting them at a high tidal volume, like 8 cc's per kg. And then you're putting them at the maximum respiratory rate that the patient can tolerate. So in vents, usually the max, you max out around like 30 to 35 breaths per minute. I'm not gonna like go into a vent lecture right now, but basically you would just want to avoid auto peeping. So you're not putting them on rate of 30 and walking out of the room. You're watching, making sure they're not breath stacking, auto peeping, and you can make the eye time, the minimum eye time that the patient can tolerate as well. So like starting at 1, you could go down just again to prevent like auto peeping since you have such a high respiratory rate. And then you're getting, so at this point, the patient's admitted to the ICU probably, but if they're still in your ED, you should still be watching them closely and following up with labs. So you should get a BBG or ABG like 15, 20 minutes after you intubate and making sure that your CO2 is where you want it to be. Again, your Winter's formula comes into play here. And there's like tables and stuff that you can follow to have goal CO2s and minute ventilations. But just like understand that vent settings are super important in these patients and you have to understand why, okay? But maybe you didn't want to paralyze your patient. Maybe you want to try awake intubation. Awake intubation, not something we do a ton in RED right now, but it's definitely in our purview. There's a study from Canada in 2016 that showed a first pass success rate of 93% with awake intubations. However, these patients were like hemodynamically stable OR patients, right? So not necessarily applying to our patient, our context, but there are like many papers out there kind of promoting the idea that ICU level patients should be considered a good population to do awake intubations on because if you're avoiding paralyzing them, you might avoid some severe consequences of that. I think just more studies need to be done about it. But anyway, awake intubation takes a little bit longer, can be like a 10 to 30 minute procedure. And there's kind of like two ends of the spectrum. You can just do like a complete topical anesthesia type of intubation, or you can do like a more dissociated using sedation agent intubation. It really just depends on how awake, cooperative, able to follow commands your patient is. So first, you want to suction. You want to really get the upper airway dry. If you, this doesn't really apply to our context, but if you have 30 minutes, you can give Clyco pyrrolate, but that probably won't do that in our ED. But suction, dry with 4x4s, and then you want to topicalize. So there's devices out there like an easy atomizer that can like spray the upper airway in the nose. And then there's devices called magic devices that can like get a little deeper and spray the vocal cords. We don't really have those available in RED, but we do have lidocaine and we have a nebulizer. So you can take 5 cc's of 4% lidocaine, put it in your nebulizer, put the rate at 5 liters per minute. The rate is important to prevent the molecules from entering your lungs. You just want it to topicalize the upper airway. And you can just nebulize that into the airway. It doesn't like it's hard to get the vocal cords that way, but it should kind of get down as far as it can. Then, if the person is awake and cooperative, you can do like a sitting up awake intubation just with that. But if the patient is more obtunded, probably like in our scenario, you want to then give some sedation agents. So most people will reach for ketamine because it's fast on, fast off, and it has like a good dissociative effect being hemodynamically neutral. So most adults will require like 2 mg per kg to reach that dissociative effect. But a lot of sources will say just to kind of give it in like aliquots of 20 cc's, wait a minute, give another 20 until you reach the state you want. Once you've reached that dissociative state, you then can do your intubation. So do we use fiber optic? Do we use VL? So most of us probably aren't very comfortable using a fiber optic scope, right? We have it, but is this the context you really want to try for the first time to do a fiber optic intubation? Maybe not. If your patient's like super awake, you have some time, maybe you can do like the nice sitting up nasal fiber optic intubation. And I'll show a video of that. It's interesting. It's something we should, know about. But there's actually a study done in 2015 that showed that it was comparing fiber optic to VL awake intubation. And it showed that the VL was a faster time to intubation, and it had the same, there's no difference in success rate or patient satisfaction. So it was 100 patients in that study, and it's not as like generalizable maybe as we want it to be, but it still indicates that VL could be a really good option for awake intubation. And since we're really comfortable doing it, something definitely to think about. You want to avoid paralyzing. But regardless of what you do, you're always having all your backups at bedside, like all your RSI meds for a full intubation in case this fails. Once you intubate the patient, remember to sedate them. They're now intubated, and then hook them up to the vent and do your appropriate vent settings. I think we have time to watch this video.
Lubricate the bronchoscope and fixate the ET tube. You may need to remove the proximal connector, but make sure not to lose it. Introduce the bronchoscope into the nasal cavity and carefully make your way into the oropharynx, looking down at the base of the tongue. Keep communicating with the patient as you proceed. If the patient experiences discomfort, retract the scope, spray more local anesthetic, and be sure to await the onset.
He's got his right hand far away. That keeps it look straight,
Place
so
the
you can
bronchoscope
rotate
just
it.
above the vocal cords. Spray them with local anesthetic. The air in the syringe will aerosolize it. Repeat if necessary. Remind the patient that they may experience coughing as you're entering the trachea. Make sure that you see the tracheal rings and proceed until you see the careen. Now hold the bronchoscope firmly as the assistant advances the tube, railroading it into the trachea. A rotation may be required as you advance. This is a good time to remind the patient that they will not be able to speak beyond this point.
Obviously, this is not our DKA patient.
Just over the end and retracting it from the careen, you can see the tip of the tube. It should be
This part is actually like when you do your sims, like the hardest part is like measuring where you're supposed to have the. But yeah, it's as easy as that, guys. So, and then just like last thing is some alternatives to, or, if you're trying to avoid intubation, here are some other things you could do. So high flow, we usually think of high flow for like our hypoxic patients. But actually there's some studies, not like amazing studies, but there's some studies and physiologically makes sense to suggest that high flow can be helpful in acidotic patients. So if you think about it, we have like anatomical dead space in our respiratory system, and CO2 is just hanging out in there. So theoretically, if you put on high flow at the max flow rate, it's going to help wash out that CO2 so that every breath you're taking, since normally when you take a breath, you're actually breathing in mixed gas, like mixed with CO2, that theoretically the high flow can wash that CO2 out and you're just breathing in oxygen. So you're like minimizing your CO2 and your minute ventilation. There are just some like case studies and some, it's just kind of like physiologically makes sense. So even if your patient isn't necessarily hypoxemic, you can consider putting on high flow, mainly for the flow rate, like max flow rate. Non-invasive is an option. However, just remember these patients are obtunded. They might be vomiting. Like just if you're going to put them on a positive pressure ventilation, you better be in the room watching them very carefully, which maybe isn't the most feasible thing for us to do in the ED. So it's an option, but it's just, you have to really watch them carefully if you're going to do it. So wrapping up our case, our lady was in severe DKA. She was resuscitated aggressively with NS fluid the first 2 hours and had insulin drip started. The 3rd hour, she was not really improving much and was also then found to have a concurrent NAGMA, given that she was getting so aggressively resuscitated with her NS. And at that point is when they decided to do a bicarb infusion and increase the insulin drip. However, the patient did not improve significantly, was therefore intubated at hour 4. They did not note in the paper how they intubated the patient or with what agents, so unclear. But she went up to the ICU. She was ventilated on SIMV mode actually. And in the ICU is given isotonic 50 MEQ per hour sodium bicarb infusions. And then her DKA resolved at 24 hours, and then she was extubated at 48 hours. So luckily for her, everything worked out, even though she was intubated. So just some pearls about the lecture I want you guys to remember: that our body changes its respiratory mechanics when we're in metabolic acidosis to compensate. That patients in severe metabolic acidosis should not be intubated. There's no sufficient evidence to suggest the routine use of sodium bicarb in acidosis, but if you're going to use it, consider using as an infusion. If you have to intubate a patient, make sure you resuscitate them and that you could consider an awake intubation. Use of VL may be equivalent to the use of fiber optic intubation for awake intubations. Ventilator settings matter. Understand the pathophysiology of your patient, and that high flow nasal cannula can help with by CO2 washout. These are my sources.